In looking at the pediatric knee, it's important to approach it in the same way as one would the adult knee, with some exceptions. And we will highlight some of the differences for soft tissue derangement in children. And we'll look specifically at four different sets of structures. One, the menisci; the second, the cruciate ligaments; the third, the collateral ligaments; and then finally we'll look at the joint space itself and look for effusion and soft tissue swelling. So let's first look at the menisci. As in the adult patient, you expect the medial meniscus or lateral meniscus to have a uniformly dark signal intensity. And one of the differences in pediatrics is that you may have a higher signal intensity, especially along the posterior horn, that does not extend to the articular surface. And it's felt to be related to increased vascularity and not a tear. So important to identify this as not myxoid degeneration, as you might expect in an adult, or a tear. Normal finding in a patient, especially one whose physes have not yet fused. Okay, so the second thing to look at is, and let's look here in the corresponding coronal and sagittal proton density fat suppressed image, we're going to look at the appearance of the meniscus and differentiate a normal meniscus from one of the pediatric phenomena known as discoid meniscus. So instead of looking at the medial, because discoid is much more common in the lateral meniscus, let's go out and interrogate the lateral meniscus. So just as we are told in adult MRI, looking at the lateral meniscus, one should expect a bow tie configuration, and you should see the body of the lateral meniscus on no more than 3 times 3 millimeter slice thickness without an interslice gap. So we see here we're far out lateral, corresponding coronal here, and there's 1, 2, 3, and we're already losing the body of the lateral meniscus. And so this is not a discoid meniscus. The other way to look for discoid meniscus is to take the mid aspect of the knee, and so we're going to go here, mid aspect of the articular surface of the femur, and look at the corresponding coronal image. And if you can see here by just the visual, you can see that the meniscus is nice and thin, and there's no body of meniscus within the joint space. But if you need to measure, because you're not sure, at this mid aspect, one should expect that the width, transverse width of the meniscus should be no more than 12 to 14 millimeters. And here it's only 8. So again, proof positive that we don't have a discoid meniscus. The meniscal tears are graded in the same way as in the adult population, and you want to determine if you have a line that is exiting the articular surface. You talk about vertical or horizontal or radial tears through the meniscus. But there is one type of meniscal tear that is more particular to pediatrics, which we'll address in the next section. So what we're seeing on this sagittal proton density non-fat suppressed image is what's known as a double PCL sign. And a double PCL sign is indicative of a certain type of meniscal tear where a fragment has flipped. We look at the corresponding image here, flipped from the outside into the inside or the intercondylar notch region of the knee. And you can see here, you're looking at this corresponding coronal image, that we have a very small horn of meniscus here laterally, and that there's a big gap, and then there's a large piece that's sitting in here medially. This is known as a bucket handle tear, and it's much more common to see this with discoid meniscus. See a portion of this meniscus that's flipped has a uniformly high signal intensity and is very thickened, and you see the diminutive anterior horn here. Looking at the contralateral side, this patient has a normal lateral meniscus with normal signal intensity and configuration. The discoid meniscus is thickened and has uniformly high signal intensity centrally, but that signal, if it does not exit into the tibial surface or femoral surface into the joint space, then one cannot call a tear. See here that this form of discoid meniscus here has a very large posterior horn and a very small anterior horn. If we look at the corresponding image here, in coronal, we see that here's that large thickened horn, and it has uniformly high signal intensity with some cystic areas here laterally. Using our rule of measurement again, if we measure horizontally in the coronal plane across this meniscus, we should expect it to measure no more than 1.2 to 1.4 centimeters. And look, this is 2.5 centimeters. So this is proof positive that this is a discoid meniscus. It's quite possible that this is a Risberg type of discoid meniscus in that it's attached to the Risberg ligament and not to the tibia, and so it is much more prone to moving around, hence the propensity for bucket-handled tears in this type of meniscus. The anterior cruciate ligament should be parallel to the posterior margin of the femur, or pretty close to parallel. This is Blumenstadt's line, which is here, and the ACL should be pretty much aligned with that. Second, ACL should have dark signal intensity with some higher signal intensity or intermediate signal intensity fibers along the posterior margin. It should be taut and not sagging, and it should attach here to the tibial spine and here to the femur. Looking on the coronal images, the same applies. We'll look first at the proton density with fat suppression. We can see that the ACL has slightly more intermediate signal intensity fibers with this border of dark signal, and this is normal. Notice that the tibial spine is intact, and a corresponding T1 showing this same dark signal intensity. In this case, there is a complete tear of the ACL. It is bowing, it is high in signal, it is thick. We'll just pan through that from side to side. What's important though to note is there is edema here in the region of the tibial spine, which we see here on the corresponding coronal image. When you see that, look for the donor fragment. And the fragment of bone that has been pulled off is right here. And this is leading to the sagging appearance of the ACL. So this is particular to children, especially under age 10 or before the growth plates have fused, that the bone is the weakest part of the ACL complex. And so the ligament will remain intact with the stresses and strains that lead to ACL tear, and instead a piece of bone will be avulsed. In the adult, it's the opposite. The bone has the most tensile strength, and the ACL is the weakest link and will lead to tear. A word about contusions and ACL tear. In children, the ACL is quite elastic, and so it might stretch but not break, in contrast to what happens in adults. So if you see the kissing contusions or pivot shift contusions, they may be at the classically lateral distal femur and proximal medial tibia. They may also be lateral tibia depending on the strain and stress. You also may see this subchondral fracture line. This may not indicate or be highly sensitive for ACL in children. Posterior cruciate ligament tears really require a whole lot of force and are uncommon in children. Usually it's related to hyperextension or multiple other injuries. In this case, the PCL, which is usually uniformly dark, is thickened, as we see here, and has high signal intensity and is buckled a little bit. And we see the corresponding images here on the axial and on the coronal where it looks thickened and high signal intensity. The collateral ligaments are interrogated in the same way as for adult imaging. The medial collateral ligament, which we see here, should be thin. It should not be bordered by any edema. If there is edema surrounding it, but it looks normal, this is a grade 1 tear. If it's thickened with surrounding edema, a grade 2, and if it's disrupted with edema, it's a grade 3. See the corresponding appearance here on the T1. It looks dark, it's not bowed, and there's no surrounding edema. And they can also be nicely interrogated or cross-referenced on the axial. Let's look at the lateral collateral ligament here, and it's really a complex of three structures. One is the iliotibial band. The other is the tendon for the biceps femoris muscle here. And then there's the fibular collateral ligament, which is here. And all three of those structures should be interrogated, and again, the same rules apply. Here is a patient with an intact medial collateral ligament, but who has a lateral collateral ligament tear. So let's see what is torn. First, the iliotibial band looks pretty good all the way along. And then we look at the biceps femoris tendon and the region of the fibular collateral ligament. Well, here's the biceps femoris tendon here, and we see the corresponding appearance here. As we start to move upwards, we see that that attaches to the muscle, which is proof positive. We come down lower and we see it sort of fades out into this abnormal signal intensity. So biceps femoris is a concern. It's either attenuated by all this fluid or it's torn. But what's more important here is look at the fibular collateral ligament. Look at how sinewy that is and how it's kind of retracted. It's got this sort of buckled appearance. And so this is a true full tear of the fibular collateral and probably at least a high-grade tear of the biceps femoris tendons. So this is a lateral collateral ligament tear. A word about joint effusion. One should interrogate the joint space and look at the character of the fluid for one, see if it's a uniform signal intensity, and two, should look along the synovial surface to see if there's any nodularity, and three, look within the joint space itself to see whether or not there are osteocartilaginous loose bodies. A lipohemarthrosis is evidence that there's an underlying fracture, and this is just when fat layers out over fluid and blood products. And so we see it here on the gradient echo sequence with some susceptibility at the interface, and we see here on the reconstructed axial image this dual layer image that suggests that there's an underlying fracture, a lipohemarthrosis.